thank you very much for your introduction and for the opportunity to present on this topic, which is violence in the emergency department. And I'm sure that anyone who has worked in emergency medicine has been impacted by violence in some way. So we're going to talk about violence, its social and cultural impact, how it impacts on healthcare workers, discuss the ED's design for violent prevention and mitigation, and just mention the concept of restraint and run, hide, and fight, which is for patients with weapons. So in healthcare, as in any other industry, violence is anything that causes harm. So that harm can be actual physical abuse. It can just be threats, harmful language, verbal menacing. All these things constitute violence and have a long-term impact on the persons who suffer them. In healthcare, our sources can be from patients with many medical conditions. So the elderly person with dementia, the young person on drugs, someone post seizures, a hypoglycemic, a patient who's been waiting all day, relatives who are frustrated because of their fear of what's happening with the patient that they brought, relatives who are impaired in one way or another. Sadly, from other staff, healthcare workers face the general public, and based on the things that are said and spoken about us as healthcare workers, the general public has a certain perception. And the thing I think that most people fear most is that criminals or gang members will come to hospital where we are treating a patient and then attempt to kill that person and harm others. This is an example of such a case. A person in Trinidad who was killed in hospital after he escaped from the gang that came to harm him and killed 3 of his friends. He went to hospital, and the gang followed him there and terrorized the entire emergency department. So, like anything else, there are many causes and differentials. Patient factors like frustration and fear, as you mentioned, altered mental status from any number of conditions. Unfortunately, males are far more likely to be the perpetrators of violence. Gangs, both in the method that I spoke about just now, and also when one of their members becomes harmed, the gang often follows him or her to hospital, and they represent a difficulty to control for the security guards. Even something as simple as cutting off their colors in an attempt to treat the patient can be viewed as an affront and lead them to violence. The environment, of course, overcrowding, people waiting a long time, everyone getting more and more upset and egging each other on, long wait times, poor staffing ratios. So I think it's time that we explain to those who deal with our staff levels that having too few nurses or too few doctors not only is directly related to patients waiting longer, but is directly related to healthcare workers being harmed. Patients who are uncomfortable obviously have a shorter fuse. If it's too cold, if the chairs are too hard, if food is too long in coming, these are all things that make people blow a gasket. if there's no TV to watch, um, these are all part of the local environment. Um, Unfortunately, nurses are 9 times as likely to be injured as doctors are, or at least to be assaulted as doctors are, um, because they have more contact with the patient. I think uh, a lack of training is almost universal um, in terms of how to deal with violence. If the staff is not trained in how to communicate with patients, how to decrease expectations to reasonable levels, that can lead to violence. And most commonly, nothing that anyone can tell. So you're doing your best. For some reason, the patient has taken an exception to it, or the relative has viewed you as a cause, and you suffer as a result. One of the interesting things is that COVID, um, I think, changed the way that people think about healthcare workers. Um, in the beginning, we had lots of banging of pots and pans and praise. Um, but as the anti-vaxxers gained more traction, um, doctors and nurses were viewed as part of the group of persons who was forcing people to shut their businesses and stay indoors and wear masks, all as part of a global hoax. So there was a loss of trust. Um, there was a 100-fold increase in the amount of violence occurring. And while it hasn't continued to rise, it hasn't gone back to pre-pandemic levels. So when faced with an aggressive or violent patient, um, one of the first things to be sure is that it is not a medical problem. So there are investigations that we may need to do, CT scans for um, subdurals, tumors, um, checks for sepsis, uh, drugs of abuse, things like ecstasy and cocaine, and alcohol level or alcohol withdrawal for someone who is a chronic alcoholic, hypo and hyperglycemia, basic blood chemistry, and liver function tests. Um, all of these things are part of our list of investigations that we should consider based on history and examination. Um, this series of graphs was taken from a Scandinavian journal looking at a German study. The things that I found interesting is that most of the episodes of aggression had no reason. Of course, the staff were the people who were most often affected. Verbal is still far more common, thank goodness. And that it occurs in closed rooms. So, as we have changed our design of emergency departments to attempt to give patients more privacy, we have led to situations where physicians and nurses and other healthcare workers are often left in a room alone with the patient with no view of the other members of our team. And it's clear that enclosed rooms are a risk. So, in terms of public health care as occurs in the Caribbean, it's often a political football. Persons come on the calling programs and uh, abuse all and sundry. The politicians say that they've given the healthcare workers all they need, and the problems are due to the healthcare workers. So, because of that, many healthcare workers are afraid to go on public transport, are afraid to tell persons at parties and social events what they do, because there's a loss of esteem they get ridiculed and abused, and they're treated as others. In other words, different. And as we can see from the current uh, exercise in the United States, when people are viewed as others, it's easy to treat them badly. The modern media, which is completely lacking in controls because anyone can publish anything they want, um, allows everyone to air their grievances, true or false, against the emergency department. Um, Unfortunately, as healthcare workers, we are bound by medical ethics and therefore have little recourse. So, talking about physical assault, the average fight lasts 7 seconds. So, we have security guards, we may have panic buttons. Um, how many people have security guards in their emergency department who come inside and respond within 7 seconds? So, the key really is prevention. Okay. In order to do that, you need to recognize the stages of aggression, um, and not ignore these sort of patients. The person who is grumbling and sighing and walking up and down, who may be talking loudly, who may be cursing, who may be saying, um, if I get my hand on people in the head, it will see. Um, that sort of behavior. Even before they get to the physical things like making a fist and having a fighter or boxer stance, are warnings of physical violence and need to be taken seriously. One of the problems in our emergency department is there's always an argument between those who think that these patients need to be segregated and treated urgently, and the point of view that treating them urgently then rewards bad behavior. But in terms of risk to the department and the people working within it, it's important that these patients get treated and moved out. So when people start to curse, when they start to do any of those things that we spoke about before, when they start kicking the wall, throwing around garbage cans, that's the time to act. Don't wait until they grab and punch a member of staff. It's time to attempt to de-escalate the issue, to leave the area, and to get help. How to de-escalate is something that actually there are courses in, because very few of us are taught that in medical school, and it's not intuitive. It's important that you listen carefully to what the patient is saying, and listen actively to empathize with the things that they say that are reasonable. Not that everyone in here needs killing, but I'm angry because they have waited all day long. Where possible, after they've said what their piece, try to repeat it and try to get them to clarify any questions that you have and summarize the things that they have as issues and see what you can fix. It's important at this stage not to offer false hope. So if you can't see them in 10 minutes, don't say that we will get around to treating you as soon as possible, because when that 10 minutes or half hour passes and they still haven't been seen, then you won't be able to de-escalate again. You've lost trust. Okay? So try and think of what you can offer. Would you like something to eat? Can we get you something to drink? Are you cold? Those are simple things that may be within your power. When they go too far, it's important to have your own personal line in the sand. That point where you will go just that far and no further. In order to do that, you need to be sure that security is nearby, because again, as we said, it only takes 7 seconds. If the escalation fails, then you need to tell the patient, this is it. So I'm trying to help you, but it's important that you quiet down a little bit, because you're really upsetting the patient next door who's sick. We'll try to see you as soon as we can. But right now it's really busy. But if you haven't eaten, we'll get you something to eat. And we have a shower where you can have a bath if you need to. Okay. One of the other suggestions was that we might have to ask the patient to leave if they can't behave. The problem with that, though, is that if we consider all the options within our differential diagnosis list of things that are serious and major, that isn't often the safe way to. So this is now the very last resort. So the patient begins to walk towards you. It's important that you are not blocking the exit. The patient should have a way out, and you should have a way out as well. If you're cornered or have become cornered because of moving to avoid the patient, and you are unable to avoid his assault or her assault, then everyone, every nurse, every doctor, every person on the street has a right to protect him or herself. So if possible, and you are trained, try to minimize harm to the patient by restraining them appropriately. If not, do anything you can to save yourself. That is your one responsibility, to get home safe. So if you've had to call in security, or you've had to call in your restraint team, or your other staff members, whoever does it in your emergency department, then you restrain the patient in the correct way. So one arm up, one arm down, ideally supine with the head elevated to prevent aspiration, and both feet restrained. The restraints are tied to the frame of the bed and not the sides. Remember that restraint is a procedure like any other. It has its indications. So restraint should not be used to punish patients, but to control those who can't be controlled by de-escalation or any other means. It's a process. It requires a team to be done safely for the patient and safely for the person putting on the restraints. That team will often be 4 or 5 people. There are contraindications. So we don't restrain someone because they said something we didn't like, made an insult, etc. It has to be within the limits of our real fear of harm or harm to other patients, that the patient needs to be restrained to limit their access to other persons. There are innumerable complications: dehydration, muscle injury, fractures, aspiration, myocardial infarction. So this is not something that should be done lightly. You need to document when the restraints go on. You need to document that the patient is monitored during the procedure and afterwards, that when they're being removed, it needs to be checked to make sure there's no obstruction of vessels, any injuries caused by the restraints. Remember, patients have died while being restrained. So it's important that patients aren't restrained, and once they're under control, that we walk out the room and leave them. Someone has to monitor the patient. Okay? So when dealing with a violent patient, failure to recognize a medical cause is an important pitfall. So just saying that the person has a behavioral issue is really a diagnosis of exclusion. We should look carefully and make sure there's nothing that can be treated because agitated deliriums um, include a wide range of lethal conditions. Failure to recognize the danger signs of the person who is walking up and down the corridor, cursing, um, and making an early intervention, that is also a danger. Because if you do that, you then get the next stage to go from just doing that and throwing things around to choking, grabbing, cuffing other members of staff or patients. Even turning away patients who have been aggressive in the past or who are aggressive at the door is a risk because you may fail to exclude serious diagnoses or serious psychiatric causes. We could turn a patient away and they go outside and harm a person. So, thank goodness, in the Caribbean so far, weaponized violence against healthcare workers is relatively rare. Um, Usually, it is a result of some criminal activity, um, but it requires active shooter drills within the hospital or healthcare setting. It requires practice of the lockdowns that are needed to manage it. The first option for you as a healthcare worker is to run. The exit should be chosen beforehand and should be away from the shooter, obviously. If you're unable to run, then the poor second choice is to hide, especially if the patient means you or healthcare workers in general harm. Hiding in an emergency department is a pretty difficult proposition. And lastly, fight. So if have no other choice and believe the person to be trying to harm you, you're entitled to hit them with whatever you can find. Um, so run first, hide second, fight third. So going back to 2002, one of our residents, uh, who I should admit now is my wife, did her research project for her postgraduate degree in emergency medicine on violence. Um, so it's been something that's been happening in our emergency department for many, many years. And it goes, again, as you look at the list, it's quite obvious that males outnumber females. And the females include even the elderly. So the demented patient may bite, stick, scratch you. Um, Again, most people are abused or cursed. Luckily, the minority are physically assaulted. Um, but after either seeing or being yourself involved in a violent episode, nearly 70% of patients felt affected in their safety at work. 30% felt rarely or never safe, and nearly 40% only felt safe sometimes. So it has a real impact on patient satisfaction, on doctors or nurses' satisfaction and enjoyment of the job, and leads persons to leave the emergency department. Um, as we look through the recommendations, these are all things that we have found over the years to be true, that individual rooms should have alarms, but we got to remember that unless you can respond to the alarm very rapidly, um, it may not be helpful. The need for a direct line to the police. We were tried even requesting a police outpost within the emergency department, having safe rooms, either for staff to escape from an aggressive patient or to hold an aggressive patient. All of these things have been considered. Certainly, what we use now, we do have metal detectors, security cameras, um, some attempt at visitor identification, and there are panic buttons. So remember that we are probably the most expensive thing that the emergency department has, the staff. It's taken many years and lots of dollars to train us. So it's important for the institutions to keep the staff happy so that they can continue to work and help the general public for years to come. That can happen if as many as 2/3 of them are attempting to avoid violent patients, and even 10% of them feel less willing to work with patients. So we recently moved from the brightly colored area on this architectural drawing to the newer area, which is in front of it. And we now occupy virtually twice as much space. This, however, has led to us having to need, if you look at the red squares or diamonds, these are all positions where security guards now have to guard entrances to the emergency department. There are at least 6 of them. So there are several distant spots which persons can gain entry to the emergency department. We do have metal detectors at the front of the emergency department and the ambulance area on the right side, the 2 red squares. But unfortunately, emergency medicine often deals with patients who may not be able to wait for persons to go through the process of scanning. So there is a possibility still of weapons getting through the screening system. This, as we said, contains several areas of closed circuit TV, but this is only useful, of course, if you're looking to identify someone after they harmed you. Okay. Accreditation, because the request was for increased privacy, as we said, led to increased seclusion, and therefore a greater number of areas where persons are at risk. Just about 2 weeks ago, there was a mass shooting at an area not far from the hospital. So the fact that there is violence in the community means that the emergency department is more at risk. A video was shared of that shooting, which showed a gunman going from person to person, delivering headshots to individuals who had been injured and who are obviously on his list. And you can imagine that caused a great deal of trepidation among the staff of the emergency department. That gunman or persons with a similar attitude would come through the emergency department. So again, run, hide, fight. So 20 years later, we had another set of research, and it again showed that physical violence was relatively rare, but unfortunately, as most studies have shown, the action of emergency staff to being threatened or abused or even hit is to take no action. As many as 70 to 80% of people never file a report or make a complaint because they just view it as part of the emergency department experience. And this is even more true for verbal abuse than it is for physical abuse. So again, almost 2/3 of persons who work in the emergency department experience violence of some form within a year. And again, this is in keeping with the numbers that we see here. All right. So the things to remember: the violence is seen by healthcare workers, administration as part of A&E. It can't be avoided, but we need to find some way to do it better. Violence is part of the community. Emergency medicine and emergency departments are part of the community. So if you're not seeing violence as yet, it's almost certain to come to you. Some effort must be made to mitigate against the effects and to prevent it from occurring. Design and security have limited impact because fights, assaults can occur within 7 seconds. There's lots of talk about zero tolerance, but what does that mean for an ED? It sounds good, but what do you do when a patient is making lots of noise or threatening someone? You still need to see them. Where faced with the aggressive patient, de-escalate, disengage, notify security, set the line in the sand, and protect yourself. And again, I would really advise whenever you see someone with a weapon, especially a firearm, first of all, run. Okay? So these are my references. Any questions?
Dr. King, thank you for sharing such a wonderful and detailed presentation. If there are any questions, can we post them in the Q&A tab? All right, so I think no takers, Reggie. So very, very clear, very concise, and we appreciate you very much. To both of our speakers tonight, thank you for sharing your expertise. To participants from all across the globe, thank you for logging in and making the effort. For those who are from the Latin American parts of the chapter, thank you for using the translation today. On behalf of our president of WADEM, Dr. Donald Donahue, thank you all for being here, and a reminder of the WADEM conference that will be held in 2025 in Tokyo. The LATAC co-chairs are Dr. Diaz and myself, and of course, Sandra Castelblanco, who was unfortunately not here today. And of course, I must thank Andrew, who's always behind the scenes to make sure that these webinars are a success. Please join us in December for our 4th webinar of the year, and that'll be the conclusion. So thank you all for logging in today. Thank you to our speakers, and see you all on the next one.